All right, thank you very much. We'll go ahead and get started, and then we'll take another coffee break soon. So what I'm going to talk about is imaging of the temporal bone. And I understand temporal bone is a very challenging topic, and I only have 30 minutes to go over it. At the American Society of Head and Neck Radiology, oftentimes we'll have 3 hours just dedicated to the temporal bone. So what I'm going to do is really sort of hit the highlights of the temporal bone and just talk about some of the common abnormalities. And I understand, like, most of you are probably not going to remember much of what I say, but at the very least, if I can give you some understanding of the common pathologies that will run in the temporal bone, then I think that's really what I hope to accomplish. And again, not scare anyone with the temporal bone. I'm going to put on my timer. We Americans, we like to be on time, so there it goes, right? Right.
I am Egyptian and I wasn't on my time.
You did a very good job. I'm very, very, very impressed. So one thing about the temporal bone, when we look at the temporal bone, we have to look at how we image the temporal bone. So when we look at CT scans, when we perform our CT scan, we always, now in the US, are performing very thin sections. And they go from anywhere from 0.625 to really 0.5 millimeter thick sections. We always acquire images direct axials. And now what we're doing in the US is that we're reconstructing everything into the coronal plane. In the old days, we would actually do direct coronal images, but now we're performing coronal reformats. And this is just one of the first cases that I ever saw when I was a junior faculty just after my fellowship. And it makes a couple of important points. So number one, when you look at the disease here involving the right temporal bone, you can look at this and say, well, is it mucosal thickening? Is it cholesteatoma? When I first saw this, I was trained as a fellow to do very detailed imaging. But when I saw this, I was new at my new institution, and I was really smart at the time because I was just finished my fellowship. So I realized the older I get, the dumber I get, actually. I was very smart when I was younger. And as I get older, I realize I'm not as smart as I thought I was. And I thought, well, I don't need to do all these fancy things because I see some disease here. The ossicles look normal to me, and so on and so forth. Well, it turns out this was a big cholesteatoma that eroded the ossicles and extended actually into the middle ear cavity. So after that, what we ended up doing is we ended up changing our imaging techniques. So this is just an example here of the normal anatomy. So when we look at the internal auditory canal, this is the cochlea here, right? Now you just sing out the anatomy. So what's located here, anybody? The vestibule. Here's our internal auditory canal. Do we know what this bone here is involving the middle of the cochlea? It starts with an M. Modiolus, right, exactly. And then we have the ossicle that's anteriorly. That's the what? Anybody? That's the manubrium anteriorly. And then this ossicle back here is the incus, and then this guy, this is easy. What's this right here? Stapes. And what window is located here? Oval window. And then what's located here that's extending inferiorly? The facial nerve. That's exactly right. So now in the US too, is we're reformatting all of our temporal bones into this Paschal and the Stenvers view. And the reason we're doing that is because there was a disease entity described a while ago that was dehiscence of the superior semicircular canal. So when this was published about 15 years ago, then all of a sudden we started reconstructing all of our images into a parasagittal and an orthogonal sequence. And this just demonstrates here a little bit of dehiscence in that semicircular canal. So it is important to identify this. The more and more as I talk to ENT surgeons, when we say this is present on imaging, there's not as much enthusiasm by the surgeons to go in and actually repair this. I just came from Alex ORL meeting, and a while ago there was a lot of enthusiasm, but this is such a difficult surgery to perform because this dehiscence is located right at the skull base, so the surgeons would have to go in, do a craniotomy, then lift up the middle cranial fossa, put a patch on. So oftentimes I think people are treating this now much more conservatively. MR, I'm sure you're doing MRI scans for patients with hearing loss. The key thing that I want to point here is that make sure your slice thickness is less than 3 millimeters. And also, when you're looking at patients with hearing loss, this is a head and neck conference, so we're going to be looking for vestibular schwannomas, also known as acoustic neuromas, but the real term is vestibular schwannomas. But realize other things can give you hearing loss. So especially in adults, you always have to look for other abnormalities, especially multiple sclerosis, because multiple sclerosis, remember, can give you hearing loss. So in the US now, we're all doing these heavily weighted T2 weighted sequences. This was performed at 0.29 millimeters. And it gives you a very nice view here of in this case, the cochlear nerve, and very nice views of the cochlea. And we can get some very, very elegant reconstructions as we see here. So let's talk a little bit about the anatomy. So there are 4 nerves that run in the internal auditory canal. So this was the classic Netter diagram, and the 4 nerves are the following. And you may have heard this. There's a mnemonic we use in the US. Anybody know the mnemonic? 7-Up, Coke Down. Exactly right. Excellent. Where did you train anyway? That's really like, who taught you? Wow. So 7-Up, Coke Down, right? So the 7th nerve, that means 7-up, which is the 7th nerve is anterior and superior, as is seen here. So then there's another nerve that's posterior to it. And the posterior nerve that's superior but posterior is the superior vestibular nerve, as seen here. So that's the superior vestibular nerve. Then, when we go a little bit inferior, we have the 7th nerve that's up, and then we have coke down. And coke down is the cochlear nerve that extends into the cochlea. And the nerve that's posterior to it, if this is the superior vestibular nerve, then this is the inferior vestibular nerve. So, and when we look at the parasagittal images and we do it just right to get ourselves oriented, this is posterior and this is anterior, right? So we have one nerve here. So what nerve would this be if this is anterior and superior? Someone tell me. Facial nerve. Then which one's going to be inferior? Cochlear. Then this is the superior, and this is the, that's perfect. You got it right. That's exactly right. And this really is that anatomy that we always see in the internal auditory canal. So here's our vestibular schwannoma. I think everyone can see this. Sometimes, if you like sweets, sometimes this is referred to as an ice cream cone here. Do you eat ice cream in Egypt or not? Yeah, that's it. I know the sweets are good. We had like 4 desserts last night. You guys like your food. I asked someone last night, what time do you normally have breakfast, lunch, and dinner? And someone told me, anytime. Anytime. And I said, that's a good way to live. Good way to live. So that's a typical vestibular schwannoma. And the point that I wanted to make here is that when you perform your heavily T2 weighted image and you look at the ear here, you can actually see the abnormality. You see the little abnormality here? You see this right here? So you can start picking up 1 to 2 millimeter schwannomas if you do thin section imaging. And I would actually suggest this enhancement right here is easier seen on the T2 weighted images than on the contrast enhanced T1 weighted images. Because when you do the contrast enhanced T1 weighted images, oftentimes we'll see vessels that are enhancing. We can see, in this case, a portion of probably the facial nerve that's enhancing. We can see the petrous apex that typically has fat that can also enhance. So and for me, sometimes the conspicuity of these lesions are better seen, the smaller ones, on the heavily T2 weighted images. All right, so let's talk about some of the diseases that can involve the temporal bone. So how many of you have heard of otosclerosis? Has anybody heard of otosclerosis? So what exactly is otosclerosis? So what otosclerosis is, it's a unique disease of the temporal bone. It typically involves more females than in males, and it's bilateral up to 60%. So when we look at otosclerosis, it's primarily a clinical diagnosis. So our ENT surgeons make the diagnosis when they perform audiology. So there's a classic appearance to it. But having said that, we're getting better and better with CT images. If you can scan something for less than a millimeter, that tells us that we're really getting some detailed anatomic information. So what I want to do here, again, is go over the normal anatomy, because again, I don't know how much temporal bone you do, but we've got some time here. So what structure are we looking at here? What's that, cochlea? And this is the vestibule, right? And then what window is located here? Oval window, right. Now, what structure is located right here? This is the, what ossicle is that? Malleus. And then what ossicle is this? Incus, exactly. So this is what we referred to, again, if you like food, ice cream cone. I like to play golf, so I consider this a golf ball and a tee. I don't know if is golf big in Egypt or not? No? No? Yeah, sort of anyway. So it looks like a golf ball to me here. And then this is the descending portion of the facial nerve. This area just antuit to the facial nerve, descending is the facial nerve recess, and this is the sinus tympani that's located posteriorly. Now, when we look at the oval window, right, here's our oval window here, and does anybody see an abnormality involving the anterior aspect of the oval window? Does anybody see this area right here? Right there? That's the absorption. This is what's referred to as fenestral otosclerosis. So what otosclerosis is, it's a little bit of rarefaction of bone, and the earliest location it arises from is the anterior portion of the oval window. And this area has a specific name to it. Does anybody remember the name? Anybody heard of it? It's called the fistula anafenestrum, and it's located right here. And this is what we see in the earliest cases of otosclerosis. Now, if you go back and look at the textbooks, you'll say, we're making this up. He photoshopped this, right? But when you go back and look at the textbooks, and this is from Shutnick's textbook that was written in the 1950s, you can see that this is the oval window here. And everyone see this bone right here, this forearm bone right here? This is actually histologic correlation or documentation of this otosclerosis that's involving the anterior aspect of that oval window. So this is what is seen histologically, and this is what we see radiologically. Everybody see that? Now, they call it fenestral otosclerosis because do you know what fenestrum in Latin is? Window, exactly right. So when you have otosclerosis that involves a window, specifically the oval window, then that's what's referred to as fenestral otosclerosis. So if you have a fenestral otosclerosis, what do you think the other type of otosclerosis would be if it arose behind the window? Somebody said it, retrofenestral otosclerosis. So otosclerosis can involve the oval window, but when the otosclerosis occurs posterior to this, then it can involve the area surrounding the cochlea, and this is what's referred to as retrofenestral otosclerosis, or sometimes it's called cochlear otosclerosis. So there's two types of otosclerosis that can involve the temporal bone. And how we identify it, again, is we look for this rarefaction of bone that surrounds the cochlea. Now, one thing that I have probably missed in the past is that when patients present with hearing loss, we tend to look for vestibular schwannomas. When we give contrast, we always want to see if there's anything arising in the internal auditory canal. So we talked about that. But we have to be aware that other diseases can also result in hearing loss. And one of those diseases is retrofenestral otosclerosis, and we know that it's surrounding the cochlea. So one of the things I always have to make myself do is to look for abnormal enhancement surrounding the cochlea, because sometimes we will miss this if we don't see it. So if I go back one slide, see this rarefaction of bone here? Otosclerosis is hypervascular. So if anything's hypervascular, we're going to see more enhancement when we give contrast. So when we do an MR with contrast, then we are going to see this abnormal enhancement involving the cochlea. So it's just one of those things to look for. And remember, if you're not sure, you can always compare one side to the opposite side. And the other thing too is use your history. I will not read a temporal bone CT or an MR if someone just says hearing loss. I want to know what side the hearing loss is on. Okay, so you can always go back, make a phone call, but if you have vague history on this, I can assure you you're going to be missing pathology. So try to get as much history as you can. Okay, any questions on otosclerosis? It's okay? All right. So the next thing that I'm going to do is I'm going to talk a little bit about inner ear malformations. And I know this is really, really hard, okay? I know it. Because I remember when I was a resident, I was panicking. And I said, when I was taking my boards, I said, what if they show me a temporal bone and it looks weird? And so my attending told me, just say Mundini malformation and go on with it, right? So yeah, I share your pain, right? So when we look at the normal anatomy of the cochlea, we have the cochlear nerve coming in and it wraps around this bone that's referred to as the modiolus or the modiolus. And then the cochlea has 2.5 turns to it. We have the apical turn, then we have the middle turn, and then we have the basilar turn. All right. And then we have these little bones right here that sort of tether and create almost like cauliflower and pull things towards a center, and these are referred to as the interscalar septum. And when we do our high-resolution T2 weighted image, we can actually see this, and we can see this membrane right here, which is called the basilar membrane. And with the leap of faith here, you can actually see a line right here. Everyone see that line? That's the basilar membrane. So we really do get a fair amount of information, and for me, it's quite amazing. Like I said, I trained in the last century. And so when I learned anatomy of the cochlea, I learned it by looking at histologic textbooks, but the detail that we get right now with MR, especially 3 Tesla MR, for me is quite amazing. So being a neuroradiologist, we have to be familiar with a lot of things, right? So we have to learn about anatomy, we have to learn about pathology, we have to learn about CTs, we have to learn about MRs. Earlier we heard a great lecture on perfusion and diffusion imaging, right? But we also have to remember embryology, right? And embryology is something that I know we all learned about in medical school. We probably conveniently forgot. But what I'm going to do is I'm now going to give you a primer on embryology of the inner ear. And if you can remember this embryology, how many of the doctors here went to medical school? Just 3, and these 3 here. Right. So, when we were in medical school, you probably took a course in embryology, right? So what I'm going to do is renew your embryology. So when you look at the inner ear structures, it all starts off with this. And anybody remember what this is called here? There's the answer. It's called the otic vesicle. So the otic vesicle is the primordium that eventually leads to the formation of the normal structures of the inner ear, which include the cochlea, the saccule, the utricle, and the semicircular canals. And that's all formed from the otic vesicle. So if you have a pathology in which you do not have an otic vesicle, then you're not going to have an inner ear. And in fact, this has a specific name to it, and this is a very rare malformation. But it's something you can diagnose if you're aware of it. So on the top here is a normal appearance of a temporal bone. So here is the intralaudatory canal. This is our cochlea. This was our vestibule. What ossicle was this right here? Malleus. This was the stapes, exactly right. And when you look deep to it, our cochlea and our vestibule. Now, take a look at this image right here. What's missing? What's that? Half the temporal bone, right? There's no cochlea and there's no vestibule. And this is what's referred to as a very rare anomaly called the Michel's anomaly. And it's an anomaly because no otic vesicle is formed. So this is just a very rare malformation, but it can be explained by the embryology. Now let's say you have the cochlea, the otic vesicle being formed, and now you have the development stops. You have an arrest in development. Well, now this is going to look like this. Can I convince you that this really looks a lot like this? Right? So this is what's referred to as a common cavity malformation. Has anybody heard of a common cavity malformation? this is what a common cavity malformation is. It's essentially the otic vesicle is formed, but it never develops, and it retains its primordial structure, which basically just looks like a balloon. So that's the common cavity malformation. Now, what if you have a little bit of formation of the cochlea and a little bit of formation of the sacral and the utricle, but then it stops? So now you can have something that could look like this, or something that could look like this, and this is what we refer to as cochlear hypoplasia. So in this particular case, can I convince you that that blob has sort of started to form? This seems like it's forming something, and this seems like it's forming something. It's abnormal, but it looks like there's some type of separation. And similarly, in this case on the right, looks like there's something forming here, and there's something forming here. So these are both two types of cochlear hypoplasia. So the cochlea and the vestibule start to split off, but then you see this red line at the bottom here, you have the arrest in the development. And as a result, you have this primordium formation here of a little bit of cochlea. And this is what's referred to as a cochlear malformation. Excuse me, cochlear hypoplasia. You with me? All right. Now, what is a Mundini malformation? Has everybody heard of Mundini? Right? So I would encourage you to do this, especially if you really love head and neck, because I can feel the love. Everyone wants to be a head and neck radiologist now, right? So there's a really nice article written in the American Journal of Neuroradiology about 20 years ago where they took Carlos Mundini from Mundini malformation and took his article that was originally written in Latin and translated to English. And it was really amazing what he found, because what Mundini found was this. This is a normal formation of a cochlea on the left, and this is the appearance of a Mundini malformation on the right. And what it is, it's fusion of the apical and the middle turns and a normally formed basilar turn. So the basilar turn is normally formed, but there's fusion of the apical and the middle turns. So maybe you'll see this, maybe not. There we go. So on the left-hand side is a picture from Shutnik describing the Mundini malformation. So there's fusion of the apical and the middle turns, and there's a basilar turn. Now take a look at the images here in the middle and the images on the right. Let's start with the image on the right. What is this right here? What turn the cochlea is this right here? The basilar turn. Looks pretty good, right? Now this is a combination of fusion of the apical and the middle turns. So this is the classic Mundini malformation. Right? This is what I was taught to say if I didn't know what was wrong. But now if you understand the embryology, you now know what a Michel's is, you now know what a common cavity is, you know what cochlear hypoplasia is, and you know what a Mundini, just by understanding that normal anatomy. Okay, so the last two things that I'll talk about is labyrinthitis. So what is labyrinthitis? Labyrinthitis is basically just an infection of the inner ear. And there's an acute phase and a chronic phase. And the way we classify it is that we can classify it based on the germ, whether it's due to bacterial, viral, syphilitic, fungal, etc., or we can classify it based on the route of spread. Is it due to an infected middle ear infection? Is it due to meningitis? Is it due to bloodborne, or is it traumatic? So this is an example of acute labyrinthitis. So histologically, we now are experts, right? So what structure are we looking at here on the right side? The cochlea, right? And if you, all these arrows point at pus involving the cochlea. See this right here? That's all pus involving the cochlea. So this is labyrinthitis. Now, if you have an MR, as we see here, MR, and you give contrast, I'm going to draw a line down the middle. If you have pus in the cochlea and you give contrast, what do you expect to see after you give contrast? Enhancement. Anybody see enhancement? So compare this side to this side. Everybody see enhancement here? Right here? Yep. That's not pointer's not working very well, but see that right here? So that's all enhancement of the cochlea. Now, what's this labyrinthitis due to? If we look just lateral to it, we can see all this disease in the middle ear. So this patient had a severe middle ear infection, and it spread into the cochlea. Everybody see that? Now, I have to tell you, I don't know what it's like here in Egypt, but in the United States, we rarely see this. I think most patients are treated appropriately. In fact, in the United States, they're probably overtreated for middle ear infections. So we don't see this as much. But this is something that we do see. So before, I showed acute labyrinthitis. And now I'm going to show you what chronic labyrinthitis looks like. So the way to think of this is that if you cut yourself, right, if you cut yourself once and you bleed and it heals, everything's okay. But if you cut yourself over and over and over again, what ends up happening to your skin? You end up forming a what? End up forming a scar, right? A scar. So the way that I think about this for a chronic labyrinthitis is that if you have an infection of the inner ear and it's not treated, how does the ear react? So on your skin, you're going to end up forming a scar. You're going to have some type of fibrous tissue forming. Well, it's the same thing in your inner ear, except what happens is that you have all this fibrous and all this osseous tissue forming within the channels of the cochlea. So this is all fibro-osseous obliteration of the cochlea. And when we look at the CT scan, can I convince you that there's a cochlea here, but it contains all of this high attenuation? That's all ossification and fibrosis. So that's why we refer to this as obliterative labyrinthitis, because the labyrinth has been obliterated, or labyrinthitis ossificans, because there's ossification. In fact, if you look really closely here, you can sort of see where the vestibule is, and the vestibule also has high attenuation within it. So again, this is ossification involving the vestibule. You can look at this again on CT histologically. I always like to show my histologic sections. This is what it looks like. And this is what it looks like on CT. In this case, the cochlea is completely gone. And in this case, on the right-hand side, this is the heavily T2 weighted image, and the normal signal in the cochlea is gone as well too. All right? Now, the last thing that I'm going to talk about, and then I think we break for another coffee break, right? See, you get a break from my droning on, is the disease that we most commonly evaluate when we're evaluating a temporal bone, and that is cholesteatoma. So what exactly is cholesteatoma? This is the definition of cholesteatoma: keratinizing debris that arises from the desquamation of the epithelium. I have no idea what this means. I have zero idea. What cholesteatoma to me is skin growing in the wrong place. Okay? Now, when we look at cholesteatomas, they can be congenital or they can be acquired. I'll talk about congenital cholesteatomas later, but I'm going to talk about the acquired form. And this is the way to think about a cholesteatoma. So, what's the most rapidly metabolic organ in your body? Does anybody know what that organ is? It's your skin. Your skin is always turning over. And what lines your external auditory canal? Skin, right? So your skin is rapidly turning over in all parts of your body. Now, when your skin normally turns over, it's not nice to think of it, but somehow all that skin is leaving your ear, right? Now, what happens is that we talked earlier about this, is that your middle ear is connected to what part of your body through the eustachian tube? It's connected to the back of your pharynx. So normally what happens is that that eustachian tube is open and it's patent, and what it's doing, it's having external pressures, and the vectors are pushing this way. And when your vectors are pushing out, that's taking your skin and pushing it out of your ear. But if you have an infection as a kid and you obstruct your eustachian tube, then what happens? All of a sudden, the vectors shift. Now, how many of you have experienced this in your day-to-day life? Has anyone ever been in an airplane? What happens when you land or take off? What happens to your ears? Yeah, that's because your eustachian tube is closing up. So how do you open your eustachian tube? You can have gum, you can yawn, you can... Ever blow your nose like this? Yeah. So you're forcibly opening your eustachian tube because you want to reverse this. But if your eustachian tube becomes irreversibly occluded, what ends up happening are the vectors go this way. Now, this structure right here that's located right at the malleus is called the what? It's the tympanic membrane, right? So if the vectors reverse, the first thing that you're going to have is that you're going to have retraction of the tympanic membrane. And does anybody remember the two parts of the tympanic membrane? There's a pars something and a pars something. Flaccida and tensa. Exactly right. So the first part of the tympanic membrane that's most likely to be retracted is the what? It's the pars flaccida. It's flaccid, right? So the top part of the tympanic membrane is the pars flaccida. So this becomes retracted. This is called a retraction pocket. And remember all that skin that was supposed to leave? If all of a sudden everything's reversed and it starts coming this way, the first place where the skin goes is here in this retraction pocket. And if this gets bigger and bigger and bigger, this is how you form a cholesteatoma. Now, anybody know the name of the space that's located here between the scutum and the head of the malleus? That's Prusak space. How many people have heard of Prusak space? So okay, that's Prusak space. And if you ever wonder why cholesteatomas were described in Prusak space, that's the reason why. Because the pars flaccida becomes sucked in, it starts accumulating all this skin and debris, it gets bigger and bigger and bigger, and eventually you have cholesteatomas form. So how do we make the diagnosis of a cholesteatoma? I just wanted to show this case. This was a retraction pocket involving the cholesteatoma. This is the malleus, this is the scutum, this is the top of the tympanic membrane. Everyone see that? That is a true pathologically proven retraction pocket. So what we look for on CT is we look for a soft tissue mass that's associated with bone erosion. So you have to have some type of ossicular erosion. So here is the malleus, this is the stapes, and what's missing here? Incus. If this is the head of the malleus, what's missing here? The short process, the incus missing. So we as a radiologist, the only way we can be sure that we're dealing with the diagnosis of cholesteatoma is if we see a soft tissue mass associated with bone erosion. Here's another example here, a cholesteatoma. And look back here in the mastoid air cell. Here's the normal labyrinthine bone of the mastoid air cell. This is something called Kerner's septum. See the soft tissue mass and the labyrinthine bone is gone? That's how we can make the diagnosis of cholesteatoma. Okay, those are the things that we need. On MR, I'll just say briefly that we don't do a lot of MR for initial diagnosis, but more and more we're starting to do diffusion MR, because when you do diffusion MR, it's been pretty accurate to identify cholesteatoma. In fact, the more and more that I travel now around the world, and we're a little bit delayed on this in the United States, if you have a patient that's undergone a mastoidectomy for cholesteatoma, a lot of places in Europe and in South America and in Australia, instead of performing a repeat CT, all these patients are being directly sent for MR to evaluate for residual or recurrent cholesteatoma, whereas in the United States, it's really variable. Some places are doing CT and some places are doing MR. So in summary, what I've tried to do over the last 30 minutes, we talked about technique, we talked about anatomy, and we just talked about a few of the diseases. We don't have time to go through any disease, but I would suggest to you that if you understand these 4 diseases, you're going to understand 80 to 85% of the pathology that you'll see in the temporal bone. So thank you very much for your attention.